So thanks, Aki Smith, and everybody for inviting me. It's really a pleasure to be here. Aki asked me to talk about this topic, which is great because it gets me away from talking about surgery and some of my research. So this is what I'm going to talk about. So the picture on the left is gastric cancer in its early days. This is a guy named Theodor Billroth in Vienna in Austria around 1890. And then this is me sometime last year. And guess what? We haven't really changed much in 130 years. We still got to cut it out, right? Well, yeah, I am wearing gloves, and yeah, that's a good point. That's a good point. But the cutting and the sewing hasn't changed. But you know what? So as kind of, pessimistic or whatever, that's not the word, but things have changed. And this is how it's changed. Because before, right, it was about he's the focus of the painting, right? He's the guy. And when I'm in the operating room, believe me, I'm the guy. I get to pick the music, all that stuff. But the truth is that gastric cancer and cancer care in general has changed for the better. And we kind of had one of our art people make this because I thought about it. Okay, we sit around a table in our meetings and we talk about patients. The patient's not there, but you're there, right, in spirit, in the center of the table. And you've got all these people sitting around the table talking about you, all these disciplines. And it's not just the surgeon, not just the medical oncologist or the pathologist, right? It's all these other people nowadays, right? Radiology, medical genetics, and at least where I work, the cancer researchers are right there at the table. So we have made some progress. But I'm actually going to take a little bit of a different attack today. Dr. Marshall, Dr. Taylor, they talked about like what's next, what's coming, and the excitement of gastric cancer research. I'm going to focus on the basics, right? Like we got to walk before we run. And my struggle as somebody who's at a big referral center is that I see that people still out there are still not doing the right stuff. And it makes me mad. So we're going to talk a little bit about walking before we run. So why is gastric cancer care unique? Now, I take care of a lot of different kind of cancers. So does Dr. Marshall. What do we know about stomach cancer? It's rare, right? But it's not just the rarity. And by the way, put it in perspective. I put the numbers because I got to remind myself, 26,000 cases a year. And then look at, that's, what did I put? Lung cancer? 10 times as many lung cancer cases. So it's not super common. But it's not just that it's rare. I want you to think about a few things, and this is what I think about on a daily basis. The diagnosis can be difficult. How many times have I had somebody say, well, they said there's something wrong in my stomach, but the biopsies keep coming back negative or questionable. And you think to yourself, how hard can it be to diagnose cancer? Well, it turns out sometimes stomach cancer is a little bit harder to diagnose. And staging is critical. In staging, unlike other cancers, we try to do a lot of staging up front. If you have a colon cancer, you go to the surgeon, they just cut it out, and then the pathologist tells you the stage, right? But here we're trying to do some staging up front. And the staging is not like the same as it is for other cancers. And this is where people who don't treat stomach cancer commonly can maybe forget a few things. So like I use this as an example. PET scans. We get PET scans for a lot of things. Turns out in diffuse type gastric cancer may or may not be helpful. Laparoscopy. I'm a surgeon. Laparoscopy for staging of stomach cancer is critical. If somebody out there has stomach cancer and they don't get a laparoscopy, you've got to kind of wonder, why is that? Now, there may be some extenuating circumstances, but that's not common to most cancers. Okay? We don't do laparoscopy to stage most other cancers. This is pretty unique. You guys know about endoscopic ultrasound, probably EUS. I'll tell you right now, it's highly user dependent, and it's probably not always necessary. And it probably depends on where you practice. I trained in New York City, and we didn't use a lot of EUS, but you might train or be with a doctor who trained somewhere else, and maybe they do. But there are all these little nuances, and that's my point here. The last one is this one, bone of contention, gastroesophageal junction tumors. Boy, I tell you, you get a thoracic surgeon and somebody like me in a room, woo, fireworks, okay? So all these little nuances in stomach cancer, and this is why people can get tripped up out there. So we gotta start with the basics. So here's a common scenario. A 67-year-old guy presented to his doctor. I actually just saw him in clinic last week. So this is why I put him on here. He had anemia. He's 67, never had a colonoscopy, endoscopy, blah, blah, blah. And this is what they see. So that's cancer, right? So now, it's kind of like, what are the next steps? And this is where I think I've seen Dr. Marshall and others have seen the gamut. People will be all over the place. Some will get a CT only. Some will get a CT and a PET. Some will get a CT, PET, and an EUS. Who should they see? Do they go see a surgeon first? Do they go see a medical oncologist first? I'm not so sure that matters as much, but it turns out to be an issue for some people. And then what other tests? You've heard about biomarkers. I'll touch on this briefly, but what else do you need to know about the pathology? Not just that it's cancer, right? What kind of cancer? So here's the biomarker slide. You've already heard about this. This is information that's unique to the patient or their cancer. So I'm just going to throw this up here. This is a group, testyourbiomarkers.org. I think it's led by Stupid Strong Foundation. That's just information. Go out there and you need to know HER2, MSI status, PD-L1 status, and then there are others, right? Claudin 18. This is very, very important. But again, my hope out there is that we're just doing some of the basics first, although I really think this has now got to be like one of those things that people just do automatically. So let's go back to the scenario. So this guy, this is the typical thing. He gets referred to the medical oncologist. He gets the CT and the PET, whatever. Okay. Then he goes and sees the surgeon. And this was not, this was before he saw me. Gets a Mediport. Surgeon says, okay, you're going to need chemo. Sends him back to the medical oncologist. Then the oncologist gives him 2 months of chemotherapy. Then he goes back to the surgeon. Surgeon does surgery. Does the gastrectomy, sees him for follow-up. Where does he go? Back to the oncologist. It's like ping pong, right? This guy's back and forth and back and forth. Now, all this sounds like, okay, that everything happened the way it's supposed to happen, right? But what I'm not putting in here is all the other stuff that I think needs to happen when somebody has stomach cancer. So what's missing? Is he getting the most effective treatment? This comes back to the biomarker thing, right? Did he get those additional tests, right? Did they test the tumor for HER2 overexpression? Did they test the tumor for PD-L1 or PD-1 expression, right? Those things have to happen, okay? And in some systems, the medical oncologist might think that the surgeon's going to do it. The surgeon might think the medical oncologist is going to do it. We're going to get to how you address that later. Did anybody ever do a family history? Turns out this guy had a very interesting family history of cancer. He's 67, and you might say, oh, well, it's not hereditary. Oh, guess what? Guess what? It is, or in his case, it was. But is genetic testing warranted, right? Oh, by the way, he had a 30-pound weight loss. This is not uncommon with stomach cancer, right? Well, the surgeon just said, well, go drink some protein shakes. You'll be fine. Okay? I'm going to bring up later, like these are things that are critically important to the care of the patient. It's not just that they saw a medical oncologist. It's not just that they saw a surgeon and that they did the right things, right? It's all that other stuff in there that really, really matters. So this gets to the whole point of what I wanted to talk about is what is a multidisciplinary team? Now I think a lot of people talk about multidisciplinary teams, but I think very few people actually do it the right way. So what's a multidisciplinary team? It's a team of experts, and in this case, in gastric cancer diagnosis, treatment, and kind of overall care. These are just some of the people on the team. So I say surgical oncologist because I'm not just a surgeon. I'm not just a general surgeon. I actually trained in oncology because that's the field that I want to work in, right? So I think a surgical oncologist, a medical oncologist, we don't talk a lot about radiation much, but radiation oncology. And then you have all these other specialties. The pathologist is critical, radiologist, et cetera. So these are all people that should be in that multidisciplinary team, okay? But what do they even do? Do they just sit around a table and munch on, cookies and drink coffee every Thursday? Well, yes. But they should, and I think Dr. Taylor brought this up, review and confirm your pathology. I think when we were in New York, it was about 10% of cases under re-review got, put into a different category. So that's 1 in 10 patients whose diagnosis may not have been totally accurate. And we review radiology. We resolve issues related to diagnosis and staging. Do we need that endoscopic ultrasound? Do we need that PET? So it turns out I'm a relatively bright guy, but guess what? I don't know everything. So I need those people around me to keep me in check and vice versa. Then we need to determine the most likely stage of the cancer. And this is different in gastric cancer than other cancers because it does inform treatment. This morning, before I drove over, I did a gastrectomy on a guy who I thought, yeah, I did. I'm in Maryland, my goodness. I'm right there. I wore gloves. But most patients with stomach cancer need chemotherapy up front because that's the treatment paradigm. But I thought that this guy might have a very early stage cancer. So in our multidisciplinary conference, I said, guys, I don't think, he needs chemotherapy, but we had to go through some extra things and whatever. And so I think I did the right thing for him this morning. Okay. But that's what that multidisciplinary team does. And then the last part is determine kind of the order and timing of treatment. This goes back to surgery first, like my guy this morning, versus do they get chemotherapy up front? Is there radiation involved? And oh, by the way, hey, Jeremy, did you order the tumor markers, right? My medical oncologists are really good about that. They're like, hey, you didn't mention their HER2 status, right? So all of this is what that team does, okay? And they really have to work together, okay? It can't just be, I'm the surgeon and the medical oncologist is on the other side of town, right? That's not ideal. It happens, but that's not ideal. So this is how I care for patients. Now, I do it in the context of clinical trials, right? Because everything I do at the NIH is on a clinical trial. So I think in general, any tumors of the upper GI tract require additional expertise. And I'm not saying that some cancers are easier to treat than others, but they're a little bit more straightforward, okay? Stomach, esophagus, pancreas, bile duct cancers, they're not like the, straightforward, easy to deal with cancers. So we created our multidisciplinary team at the NIH several years ago because these tumors are not like super straightforward. And I just show a picture. This is when we formed many, many years ago. But the reason why teams are important is because there are data out there that outcomes are optimal or more optimal with a team. Patients' care is maybe safer, right? You can certainly lower costs. You can improve efficiency, right? By the way, I've seen patients make multiple trips back to the surgeon, unnecessarily, right? For staging procedures and then Metaport and whatever. It's like, why not just kind of like be efficient? Patients generally are more satisfied with team-based care. And I think it just makes sense. There's some things you don't need a clinical trial for, right? There's like an old joke about parachutes. Like you don't need a randomized controlled trial to know that parachutes work, right? Okay. So the last part I'll say is you have to, as a patient, I think you really should seek out programs, not providers, right? I would say the same thing for me. You see Jeremy Davis on a billboard or something, like I use the robot and I'm super cool, whatever. You don't go and seek out the person, right? You need to seek out the program, okay? Same thing with institutions. I wouldn't go, oh, that institution, right? It's the program. Do they have all the things you need? Okay, so seek a team of experts, okay? For example, I use the example, a good surgeon's important. Of course, we're very important. We're self-absorbed and all that stuff. But a good surgeon who doesn't take care of their patients as part of a team is not going to be as effective. I'm sorry to say it. You can be the best surgeon in the world, but if you're out there on an island, it doesn't matter. So I was just talking to somebody in the back. You have to advocate for yourself. And you guys do that very well, but don't be shy, okay? I put it on here. When you go to see or you tell somebody, Don't be shy. Ask, do you have a team? Is it a real team? Fake team. Fake team, real team, right? Ask real questions. How often do you guys meet? How many patients with gastric cancer do you take care of? Ask the surgeon, how many gastrectomy operations do you do? People ask me, and I give them, I tell them my data, you know? You shouldn't be shy, meaning I shouldn't be shy and you shouldn't be shy. I'm gonna skip over this because it's late and you guys are probably hungry. But I'm gonna tell you, one of the things about this, that this is my soapbox, is like gastric cancer, I'm taking out your stomach. Do you know how many patients I know have gotten a gastrectomy and saw the dietitian on the day they were discharged from the hospital? I've talked to a lot of people, and in fact, I've worked in some really nice places in my life, and that happened. Makes no sense. How in the hell do you take out somebody's stomach and then on the way out, here's your parking validation, here's the dietitian? Asinine, okay? So I'm gonna skip over this, right? Because nutrition matters, and it matters for so many reasons, right? So what I usually tell people, and I can't remember if I put it on here, is, for instance, the dietitian is part of our team because you have to start talking about nutrition before you even initiate therapy. Don't talk about nutrition at the time of gastrectomy. You're going to be getting chemotherapy for a couple months. We need to be talking about nutrition up then. Okay, so we do a lot about that. So I want to just end on the clinical trial stuff. These are just some facts. This was data that were a few years old out of the Division of Cancer Control and Population Sciences out of NCI. 40% of Americans reported not knowing anything about clinical trials. I think the number of people surveyed or whatever was like 8,000. And only about 5% of Americans had ever participated in a clinical trial. Now, we know that there are lots of barriers. Dr. Marshall mentioned the difference between the Georgetown Hospital and the hospital center, right? Only a few miles apart, but worlds apart in other ways, right? There are lots of barriers to trial participation. And you know, some of them just have to do with not knowing what being in a clinical trial is about, right? Am I going to be a guinea pig? You know, are you experimenting on me? But clearly there are going to be groups that are not as well represented based on race and ethnicity. So I just wanted to show you a few things. There aren't a ton of clinical trials in gastric cancer on clinicaltrials.gov, but I just perused it briefly. There are about 200 interventional studies going on right now in the United States. I just looked at this the other day. Interventional study means that we're doing something. You're getting a drug or some sort of treatment. We're intervening, not an observational study. There's about 37 of those. But this is what you keep in mind, right? These are early phase studies, right? We're testing drugs, right? To see if they're efficacious, if they do anything. Well, that's that. This is just to see, like, can we give it to you without a ton of toxicity, right? We're finding a dose. This is efficacy. And then there's about 9 studies, phase 3 studies. But when I looked, about 3 of those weren't just gastric cancer specific. They included other GI cancers. So I don't know if that's a good thing or a bad thing. I mean, gastric cancer is not super common, but you know, so to have 9 phase 3 studies ongoing right now, I don't know how many studies in breast cancer there are, but there's probably way more than that. But you know what's interesting? Most of these clinical trials close early because of poor accrual, right? So when an investigator tries to run a clinical trial and then it fails or they fail to accrue, it's because they can't get patients into the study. And those are things at Dr. Rathmel's level in some ways to figure out why is that? Why aren't we getting more people into clinical trials? But they're really important. So for my clinical trials and look at all the people that I need, okay? This is one of the reasons why clinical trials are so hard to do. They cost a lot of money because all these people are getting paid, right? They're not doing it for free. But I have a big team, and I don't know how I would do it, you know, but this is why clinical trials are both important but costly. So in conclusion, this was more of a pep rally maybe. You have to insist on team-based gastric cancer care, and don't let people pay lip service, okay? It has to be like the real deal, guys. It really does, okay? Don't be afraid to advocate for yourself, okay? It's okay to ask tough questions. If your doctor gets offended, go find another doctor. I used to tell my grandma this all the time. My grandma's dead now, but when she was alive and she was complaining about her doctor, I would say, Grandma, why are you even wasting your time? Go somewhere else. Seek programs, not providers, okay? Seek programs, not providers. Yes, I'm a great surgeon, but if I'm just a guy, I'm not going to do you any good. I need a team of people around me. And then I think in general, this is just more of a challenge. We all have to work harder to improve participation in clinical trials so that we can move that needle. Okay? That's all I got.